Okay, so today we're focusing on pericardial diseases. I will discuss the echo part, and Dr. Nabi will be coming and he'll just focus on CT and MRI. And specifically, we'll be addressing whether or not all the different imaging procedures are necessary, whether they're complementary or just completely redundant. So echo really is the workhorse in the diagnosis and treatment of pericardial disease. And why is that? Well, there's no special protocols other than adding respirometry. There's no post-processing. It's very portable, which is very important because most of these patients with significant pericardial disease have hemodynamic compromise and are in the ICU. So, and also the results are instantaneous. As you're obtaining the images, you can be standing by the sonographer and you can know right away what the correct treatment is and what the diagnosis and the correct treatment is for that particular patient. So in this of course is a patient with pericardial tamponade. You can see that there's a very large circumferential pericardial effusion. You can see that there's right atrial systolic inversion and right ventricular diastolic inversion of those free walls, and that's just because the pericardial pressure is exceeding the pressure in the right atrium during systole and the right ventricle during diastole. Now, frequently in these ICU patients, we've all seen this in the echo lab where it's not this clear cut. Frequently, you don't even see the right-sided structures. So you need something more to try and determine whether or not that pericardial effusion is hemodynamically significant. You can't go by just the size of the pericardial effusion. And why is that? Well, it's because of pericardial compliance. And that's determined by how quickly that pericardial fluid collects. So if it collects slowly over months to years, as in a dialysis patient, for example, a very, very large pericardial effusion like this might not even be hemodynamically significant because the pericardium has had time to stretch and accommodate all that pericardial fluid. If it's collected very rapidly over a matter of minutes, well, then the pericardial pressure may be very high and it may be very, very significant. And that is in a case that, shows that would be somebody in the cath lab who's had an RV perforation or RA perforation from a pacemaker lead placement. So in order to determine whether or not it's hemodynamically significant, we rely on Doppler data to show us. And even in the technically difficult studies, usually we're able to get some, probably not all of the information, but some of the information. So the Doppler data is just an exaggeration of the normal respiratory response. And why is it exaggerated? Because that increased pericardial pressure from that increased pericardial fluid is causing ventricular dependence. So what that means is on the right side, when you inspire, that negative intrathoracic pressure pulls all the blood to the right side of the heart. Because the ventricles are now dependent, this is at the expense of the left side. So as you inspire, you can see that the peak E on the right side is very, very high. When you, at the start of expiration, the peak E is very, very low. Opposite is true on the left side. When you inspire, the peak E is very, very low because all the blood is on the right side. When you expire, the peak E is very, very high. Now, what happens in the hepatic veins? Well, in the hepatic veins, it's interesting. During expiration, all of the blood, again, is on the left side. So there's very, very blood flow, very little filling of the right atrium to the right ventricle on the right side. So basically, all the filling occurs during systole, and there's very little blood left. So you actually see, because the pressure is very low there, this diastolic flow reversal during diastole. So you can see this is all diastolic flow reversal on the top here during expiration, and it goes away during inspiration. Now, M mode is probably the best because of its superior temporal resolution to show you that ventricular interdependence. And if you combine it with respirometry, it just gives you a beautiful view like this. So this is your pericardial effusion. This is your RV free wall. This is your anterior ventricular septum and your LV posterior wall. This is your LV cavity. And what you see is as you inspire, the RV cavity becomes bigger because that's where all the blood is at the expense of the LV cavity. As you expire, the RV cavity becomes smaller and the LV cavity becomes bigger because now all the blood is on the left side. Now, sometimes you'll come across patients like this, and it's clear that the effusion is small, but there really is RV diastolic inversion, so that pericardial pressure is higher than that right ventricular end diastolic pressure to be causing that free wall to invert or cause that RV diastolic collapse in all of these views. However, when you look at the IVC, you see that it's completely collapsing. So that's telling you that the central venous pressure or the right atrial pressure and the right ventricular end diastolic pressure are very, very low. And they're so low that your pericardial pressure they're approaching zero. So your pericardial pressure may just be 2, but it's not enough to cause this right ventricular diastolic inversion. And when does that occur? That occurs in people who are having massive GI bleeding and people who are severely dehydrated or septic. And what you'll see is if you just give them a blood transfusion, if they're like bleeding, or if you give them IV fluids, if they're septic or if they're dehydrated, that all of these changes that you're seeing completely resolve. The Doppler would look exactly like someone in tamponade, so that's why we call this normal pressure tamponade, but the treatment is very, very different. So basically, the lowest, it's important to remember that the lowest pressure chamber always collapses first. And that becomes very, very important in people with severe pulmonary hypertension, because this is somebody where the PA pressures are approaching or exceeding the systemic pressures. And basically what you're seeing here is that throughout systole, the left atrium is pretty much collapsed here, and it only gets a little bit bigger right at the very end of systole, beginning of diastole. And you can see the LV throughout diastole is collapsed here, and it only gets a little bit bigger at the end of diastole right before the onset of systole. So it's these chambers that are collapsing because the pericardial pressure is exceeding the left atrial pressure and the LV end diastolic pressure. It's exceeding those and causing collapse. It's not collapsing these chambers because the right atrial pressure and the right ventricular end diastolic pressure is much higher than the left ventricular end diastolic pressure and the left atrial systolic pressure. Yes, absolutely there is. LV diastolic, well, the LV is kind of a slit throughout diastole, yes. LV diastolic collapse, it gets big just at the end of diastole, beginning of systole. And LA systolic collapse. So this is true where the chambers with the lowest pressure collapse first in circumferential pericardial effusions, because the pericardial pressure is generated on all the chambers equally. However, if you have loculated pericardial effusions, that pressure is just seen by the chambers that are adjacent to that large pericardial effusion. So this is an example of a patient who has a very large loculated posterior lateral pericardial effusion, and you can see that the LV, the LA is collapsed throughout systole until the very end, and the LV is also collapsed throughout diastole until the very end when it comes out just a little bit, very end of diastole, beginning of systole. So this is, demonstrating that in patients with a loculated pericardial effusion, all of that pressure is seen by those chambers adjacent. The same is true for pericardial hematomas. So here's a TEE example of a patient with a large pericardial hematoma right next to the right atrium here. And here you see the extent of that hematoma. It's quite large. And because it's just located next to the right atrium, it's causing right atrial collapse throughout the cardiac cycle. And when this happens, usually it's in a post-op patient or somebody who's had a central venous catheter placed or a pacemaker wire placed. And when this happens, because of all of this right atrial collapse, it can absolutely lead to hemodynamic compromise. Now, echo is superior to CT and MRI because it provides assistance with procedures in pericardial diseases. And so this is an example of an echo-guided pericardiocentesis. And basically, you can see this very large anterolateral pericardial effusion. You can see the needle popping through, and then you can see that ceiling contrast is given just to ensure that they're in the pericardial space. And once they've ensured that with the contrast, they start draining the fluid. So this is a routine procedure that we've all done. Now, echocardiography is diagnostic in most cases. So in this particular case, this is a classic case of pericardial constriction. And basically, what you see is that there is a diastolic septal bounce in all of these views. You can see that either there's a small pericardial effusion or maybe the pericardium is just really thick. Pericardial thickness is very difficult to tell on a transthoracic echo. You can see that there's ascites here and there's a pleural effusion here. So these are all just classic 2D findings and a pleural effusion here of pericardial constriction. If you look at the Doppler in pericardial constriction, it looks identical to that in tamponade. Why? Well, this time it's not increased pressure due to that increased fluid being in the pericardial space. It's just that the pericardium is thickened and it constrains the heart during the endodiastole. So it also is causing ventricular interdependence, just like tamponade. So basically, again, as you inspire, you're going to have more blood on the right side, so the peak is higher on the tricuspid side, lower when you expire. The opposite is true on the mitral side. The hepatic veins are interesting because the hepatic veins, what you'll see is they can accommodate all of the blood during systole and diastole except when you inspire. So you inspire and there's more blood to the right side and there's just nowhere to put it because of the pericardial constraint. So it actually, you get this little diastolic reversal just during inspiration. Now the tissue Doppler is always normal in pericardial constriction. So the E prime is always greater than 8 centimeters per second on the lateral and septal side. And sometimes you'll have something called annuli inversus, where the tissue Doppler is actually higher, the E prime is actually higher on the septal side than on the lateral. Now the M mode, if we showed it, like we showed it, and it would look identical to what it looks like in tamponade, where you have that ventricular interdependence with respiration. So echo also is superior to CT and MRI because it works for all patient populations. It works for those who can't hold their breath because they have COPD. Those who are very, very large, even though the images may be bad, they're almost always technically difficult because these people are in the ICU setting and they can't rotate, and so you can get the best images, you still can see a pericardial effusion. It works in people who are wiggling and they're claustrophobic and they don't want radiation. So it works in everybody. And in this particular case, I bring this up because this was a patient who was quite sick. He was spiking fevers. He was going in and out of AFib with RVR. He had a history of a fairly recent CAB, and the question was whether or not he could have purulent pericarditis. So you can see he's got a pericardial effusion here, and he's got a very large pocket here laterally of something in there. It doesn't look like it's just fluid. It's something. So he actually went to the OR just based on these echo images, and they sent the cultures. It was bacterial. They lavaged his whole pericardium, instilled some antibiotics, and sent him out with a pericardial drain. And he actually made it out of the hospital. And this is a disease that's 80% uniformly fatal because of the delayed diagnosis and delayed treatment in these patients. So there is a role for multimodality imaging, and Dr. Nabi he's gonna expand on this more thoroughly. But frequently on echo, it's difficult to determine pleural versus pericardial. So here's a patient, you just see echolucency all around the heart. You can't tell where the descending thoracic aorta is. You don't see it on any of these images. So it's almost impossible to say how much of this is pericardial versus pleural. This is where CT or MRI have absolutely no problems because they can see the extracardiac structures and tell you exactly whether or not you need to be concerned about a significant pericardial effusion. The other is to guide treatment of pericarditis. So this is somebody who's got chronic pericarditis. You can see all the fibrinous material in here. And the question, of course, is that inflammatory, and will it respond to anti-inflammatory treatment, or do they need a trip to the cath lab or the OR to clean this all out? And again, CMR is valuable in giving you that information, which you can't get from echo. I think another area where CT and MRI are better than echo is determining pericardial masses. It's almost impossible to determine whether a pericardial mass exists. And this is a good example. You can see that there's a pericardial effusion. You can see there's left atrial systolic collapse. You can see there's some RV end diastolic collapse. But other than that, you would think maybe this is just a pericardial effusion with high interpericardial pressures. There is an illusion that maybe there is a mass here. And this patient subsequently underwent MRI imaging and definitely had a pericardial mass and was subsequently diagnosed with angiosarcoma, which is something that you just really can't get from these echo images. This is another patient who had lymphoma, and the question again was whether or not there was a pericardial mass. You see all this stuff, and you see this, which looks like it's more in the ascites fluid than inside the heart, and then you see this, which also looks like it's more in the ascites fluid. So it's really hard to say exactly what that is on echocardiography. So again, this would be a perfect person to undergo imaging with CT or MRI to tell you whether or not that's a true pericardial mass. And this absolutely did turn out to be lymphoma. But compare that to this one, where you've got this, and it looks like it could be a tumor implant sitting up there, and you see it up here, and it looks like there is a trace amount of pericardial effusion. So you're very suspicious that maybe this is some sort of pericardial mass. But this person subsequently went for multimodality imaging, and it was determined to be epicardial fat. And I see this over and over and over again, so I don't think it's wrong if you see something like this to say, oh, it may be a pericardial mass, and recommend multimodality imaging, just realizing that the majority of the time it might just turn out to be epicardial fat. And another role for multimodality imaging is in mediastinal masses. So this is a patient who is, heart rate's very fast, blood pressure is very low. You can see that the LV is being compressed here. So he's got LV diastolic collapse, but you just don't see anything. You see that there's what looks to be like epicardial fat there, but you don't see any masses, and that's just because the field of view for echocardiography is on the heart. So this mass actually is in the anterior mediastinum, and that would be easily visualized on CT or MRI, but not on echo. So in conclusion, echo is the most often the only imaging modality needed to diagnose and treat pericardial diseases. You should consider MRI to tailor treatment of pericarditis to determine if it's inflammatory or non-inflammatory. You should recommend CT or CMR for tissue characterization and determine the extent and extracardiac manifestations of pericardial masses. And the very last one that I didn't show you images of, because it wouldn't look that interesting, is if you suspect somebody has congenital absence of the pericardium. Of course, we can't see that on echo. All you would see on echo is, because the heart is shifted left, is predominance of the RV and RA, but you can see that in people with very vertical hearts anyway, so you would not be able to tell by echo whether or not somebody had congenital absence. With that, I'm going to turn it over to Dr. Nabi.
can be used for pericardial disease. So I hope by the end of the talk, y'all will agree that these techniques are definitely complementary and definitely additive in value. Okay, so I think, I have some basic slides. I think, everybody knows the pericardium is this flask-shaped structure that encircles the heart. It's got two layers, the serous and visceral layers. And there's been some proposed theories as to why we have it. Could it be for lubrication? It minimizes friction. Could it serve as a mechanical barrier to infection? And it definitely facilitates cardiac chamber coupling and interaction. Now, pericardial diseases are a spectrum of diseases, and we'll be covering quite a few of these here in this talk. But what's important to know is frequently the symptoms are quite variable. Patients can present with, vague symptoms of chest pain and shortness of breath, and frequently you can go down a diagnostic workup through different diagnostic workups, and really it's an astute physician who really has to tie in a bunch of different imaging tests in the patient's symptoms and clinical findings before the diagnosis of pericardial disease can be made. We know, as Karla had shown us, that no doubt about it, echo is the first-line test for this disease process. However, there are limitations that we should be aware of. Patients can have very difficult echo imaging. As far as I'm concerned, I think I've seen maybe one case where I was convinced that the pericardium was thickened. Otherwise, I'm not really sure you even see the pericardium very well. And of course, tissue characteristics are, again, a real difficulty with echo. Now, both CT and CMR are advanced techniques which can be very beneficial. These are techniques that have large field of view, so you see really everything inside the thorax. And they can, of course, then, therefore, be able to visualize the pericardium in great detail. And so that is one, there's definitely an advantage there if you're dealing with pericardial disease, you should be able to visualize the pericardium. Now, each of these techniques have their strengths and advantages, and we'll be talking about that as we go along. So cardiac CT, I think all of y'all are very familiar with this technique, a great test, very high spatial resolution. You can really see things in great detail. But its biggest strength when it comes to pericardial disease is that it allows you to see calcium with great detail. And that is unfortunately not well done with cardiac MRI. Now, CT does have disadvantages, really, for pericardial imaging, we'll discuss this. You can do it both with contrast and without contrast. But where its disadvantage lies is that really you can't get functional information. If you wanted to get functional information, you really would have to do retrospective gating, and that's a tremendous amount of radiation you'd be administering, trying to determine physiology. And then, of course, with CT comes radiation and iodine exposure. Now, CMR has the advantages of CT with a large field of view, excellent spatial resolution, really ability to define everything in the chest with great clarity. But it has some very specific and unique advantages which the other techniques don't have. And what are those? Number one, because it's a physiological test, we can definitely get the physiological test with the pericardial anatomy. It's the only test that has the unique ability to be able to evaluate for inflammation. And Karla hinted why this may be important to you in your cases, and I'll show you some cases that I have. And then finally, this is a technique where frequently we see masses, as Karla had shown us, and you kind of have to figure out what this mass is, and CMR, because of its ability for tissue characterization using the different sequences that we have, is a superior technique within that. There are disadvantages, to be fair. It takes an hour to perform. Devices can be a little bit problematic. We do not see calcium. And if you're going to be administering gadolinium, you're unable to do those in patients who have acute renal failure or GFRs less than 30. Now, I guess before I get into the talk, it's important for us to be able to see what a normal pericardium looks like. This is what a normal pericardium looks like on a T1 weighted spin echo sequences with CMR. I've shown you 3 different planes, which you all are used to looking at with echocardiography. And what you'll notice is this very nice, thin, linear structure that circumambulates the heart. In general, wherever there's fat, you can very nicely see this in all this because you have surrounding fat that provides you a clear differentiation. And what you should know in general, a pericardium is generally less than 2 millimeters thick. And we consider an abnormal pericardium anything more than 4 millimeters. Here's what an abnormal pericardium looks. And I hope you remember the last images I'd shown you. It was just this very, very thin, curvilinear structure. Here, I hope you'd appreciate this looks like a very markedly thickened rind that goes all around the heart. And in this particular case, it measured more than 4 millimeters, which would be considered abnormal. What about CT? With CT, we can, of course, also see the pericardium very nicely. Things that you should know is with CT, you can see the pericardium even without the use of contrast. So the images on the left are without contrast, and you can see wherever you have surrounding fat, you can see the pericardium very, very nicely. Sometimes we have trouble in the infralateral area. This is where there tends to be a little bit less fat, and pericardium can be a little bit difficult to visualize. The images on the right-hand side are with contrast. This, of course, lights up the ventricle very, very nicely, but it should not interfere in any way with your ability to visualize the pericardium. What does a thickened pericardium look like with CT? This is what it would look like. Here you can see the myocardium. You can see this black rim would be just probably a layer of fat, and then you can see a very markedly thickened pericardium. So just be able to see, because most of my examples now are coming as cases, so it's just to get you familiar with how to look at these images. So as we had discussed, and as was discussed, really pericardial disease is a spectrum of disorders. There's about 5 different disorders in pericardial disease, and really all of them can be individual talks, but I'll try to hit on some highlights. So let's talk about effusions. How can both CMR and CT can be very beneficial when it comes to evaluating pericardial effusions. And the reason is clear. This is a technique where you're not really restricted to any particular imaging plane, and you really get with a large field of view, you're able to see the entire chest in great detail. So you're really able to very nicely be able to differentiate a pericardial effusion from a pleural effusion, from ascites, which sometimes can be quite challenging with echocardiography. Not only that, because you're able to see the full extent of the effusion, you can kind of give an estimate of how large it is, how it is distributed, and whether it's loculated or not. And remember, with loculated effusions can be sometimes difficult to evaluate with echocardiography. And then finally, both these techniques have some limited ability to be able to characterize the fluid a little bit further, and we'll show you that. So with echo, with CMR, it's important to note that, CMR, because you have many different sequences, fluid and pericardium will behave differently in those sequences, and therefore for us, it's actually quite easy to be able to differentiate pericardial fluid from pericardial thickening. I'll just leave it at that. But I make that point particularly because sometimes this can be difficult with CT when the CT attenuation units of fluid and pericardial thickening can be very close to each other. And this is just an example of that, where here with CT you can appreciate that in this particular case this is a pericardial effusion, but here's a case where you have both an effusion and thickening, and it can be a little bit challenging to the untrained eye. When it comes to characterization of fluids, CMR can also at least get you in the right ballpark, whether something is transudative or exudative. Again, it's all how the fluid behaves in different MR sequences, and basically in general, transudative fluid tends to have a very bright signal in our SSFP sequences, whereas you can see here on this exudative loculated effusion, you can see how dark the images are. CT similarly can give you some idea of the quality of the fluid that you're dealing with. In general, you can measure, the CT attenuation of it. And in general, transudative fluids are closer to water, so they'll have CT attenuations that are less than 10 Hounsfield units, whereas anything more than 20 is considered to be an exudative process. Although, we're by no ways the first line test for diagnosing cardiac tamponade, but as imagers in the CT and CMR lab, we often have to be aware of these findings because frequently these can be undiagnosed or underdiagnosed. And so this is just an example of with CMR where you can really get a feel for a very large circumferential transudative fluid around the heart. And then you can see the typical findings that Karla had spoken about to help you make the diagnosis that intrapericardial lead pressures are elevated. Here specifically, the RA systolic collapse. This case actually had RV diastolic collapse, and then the dilation of the systemic veins. Similarly with CT, although it's not moving, although not necessarily a cine, there are features that can tell you that your patient may be an impending cardiac tamponade. This is the way the heart behaves. If you have, chamber sizes that are more tubular, if they appear flattened, if you see elevations of the SVC and other systemic veins, you can bet that filling pressures are likely, intrapericardial pressures are likely elevated and cardiac output is impaired. All right, so let's move on to infectious and inflammatory disorders of the pericardium. And I'll show you this, hopefully a few cases here. So here was a 48-year-old male. He had positional chest pain of recent onset. His physical exam as frequently as was normal. His EKG just showed early repolarization, and his echo in this particular case was also normal. He underwent an ischemia workup, which was negative, and he was referred to the CMR lab for further evaluation. And here was the CMR images, and just looking at these images, I can tell you that for sure this pericardium is not normal. It appears markedly thickened. You can see this here anteriorly. You can definitely see it here laterally. And then what was also interesting is that over here in the posterior to the inferior wall, there was the presence of a small pericardial effusion. And I point that out because this will become important in my next few slides. But the way we really look at pericardial thickness is, again, these T1 spin echo sequences, and I hope now you can really appreciate this pericardial thickening that's just circumambulating the heart, showing you that the pericardium is markedly thickened. Another technique that we have is what we call T2 imaging, which is water imaging or looking for edema. And what you'll notice is that all this area that appears very thickened and black to you, which is the pericardium, on these images are this bright white, which tells you this pericardium is actively inflamed. So, and then when we administered gadolinium, and we'll talk a little bit more about this, but what you'll notice is all this whiteness that you're seeing outside of this heart is intense gadolinium uptake of the pericardium. And in fact, this is a 3D sequence of the entire heart. And as the movie plays along, what you'll notice is all around this white that you're seeing is a very inflamed pericardium that has taken up gadolinium. So what does all of this mean? If you look at the definition of how to diagnose acute pericarditis, you need at least 2 of the 4 criteria that are shown above. Either you have the pericardial chest pain, which this patient had, did not have, his physical exam was normal, he did not have a rub, and his EKG did not show anything. But where it became important was, in where CMR, I believe, was helpful in this particular case was in other supportive features that were present that can help you make the diagnosis of pericarditis. And in this particular case, the identification of a small pericardial effusion, and then with late gadolinium enhancement techniques, the ability to see diffuse pericardial inflammation. So this patient was then treated with anti-inflammatories, and actually here was his study, sorry, um, 6 months later or a few months later, and I hope you can compare it to what I had shown you. All that pericardial thickness is resolved, and yeah, actually, to be honest with you, you can't even see the pericardium well anymore. It's returned back to its normal size. And these are the LGE images here, and you see none of that hyper enhancement around the heart. Now, we have other cases of acute inflammatory conditions. Patients can have pericarditis, but CMR is the only technique that can tell you whether the patient also has concomitant myocarditis. And so this was a great case. This was a case where you can see this pericardial effusion around the heart. If you look very closely, I'm not going to try to teach you how to read these images, but I hope you'll appreciate with me the black here is your pericardial effusion. You actually, this whiteness that you see on both sides of this fluid, which is shown as black, is enhancement of both the visceral and the pericardium. So you can actually see both layers of the pericardium with CMR. But what's even more further interesting in this case is if you look at the LGE of right below the fluid level, right here in the myocardium, you'll see hyperenhancement of the myocardium as well. So this is, not only was this patient diagnosed with pericarditis, but they had concomitant myocarditis as well. And then CMR, of course, can be very helpful with post-infarct pericarditis. This was a case where you can clearly see this patient has had an LAD infarct with scarring of the apex. And here you can see then pericardial effusion. And again, this on the T2 images, I'm showing you this, where you have brightness around the fluid, telling you there's edema in both the visceral and parietal pericardiums. Okay, so there's a lot of other pericarditises that we also see that we should be aware of. This is just a case from the literature where a patient had an EP procedure. Frequently, they come back with chest pain. Here, they did a CMR post-procedure, and the pre-procedure frequently is for the pulmonary veins. The post-procedure, you can see intense hyperenhancement on edema imaging, indicating that the pericardium is actively inflamed. If you look at the delayed hyperenhancement, you again see that white rim of hyperenhancement all throughout the pericardium. This patient was put on anti-inflammatories, and you can see complete resolution of the edema and the LGE uptake in this particular case. All right, so from the acute pericarditis, let's move on now to pericardium that's more thickened and scarred, and these would be more of your chronic constrictive pericarditis, and how CMR may be able to add value. So this is a case that I saw recently when I was on the service, and every change that Karla taught you all about with echo indicating that this patient had constrictive pericarditis was present. They had restrictive filling pattern. They had respiratory flow changes that were significant both across the tricuspid and mitral inflow. They had their septal E prime was greater than 8 centimeters. They had annulus paradoxus. They had the septal diastolic bounce on cine imaging, and they had the expiratory diastolic hepatic flow reversal. This was a diagnosis of constrictive pericarditis. Now the question is, do you need any further testing? And I will argue with you, yes. So this patient just by chance happened to have a CT scan, and so I brought it because it's nice to show. And as the echo had suggested, you can now clearly see the very thickened pericardium circumambulating the heart with CT, which would be another, again, positive supporting factor, that sign that this patient truly does have constrictive pericarditis. What about the CMRs? Well, here are the images. And remember, CMR has the additional value of also being a physiological technique. And it showed a lot of the same features that what were mentioned when I was telling you about the echo findings. You had the diastolic septal bounce. And then, you can see the atria appear quite enlarged. And here you get the feeling, although we usually use, again, our T1 spin echo sequences for pericardial thickness, this is not, even in the SSFP sequence, this is not a normal looking pericardium. But here's your turbo one-spin echo sequences, and you can see again a very markedly thickened pericardium, actually measuring 5 millimeters all around the heart. So again, we didn't need this test to tell us that this patient had constrictive pericarditis. We have other supporting features. As you know, constrictive pericarditis is a disease of dissociation between intrathoracic and intracardiac pressures, and that leads to ventricular interdependence and impaired cardiac filling, and therefore elevation of decreased cardiac output and increased filling pressures inside the heart. And so you can see secondary features, both with CT and CMR, of the presence of elevated filling pressures. So here you can see IVC plethora that doesn't decrease with inspiration. You can see enlarged atria, you can see the pleural effusions, you can see the hepatomegaly, and you can even identify ascites very easily. On top of that, just to show y'all that just with transthoracic echo, we can see evidence of ventricular coupling, and in this particular case, the diastolic septal shudder that y'all are used to seeing. This is an example of that. And then, more importantly, we have the ability to, just like with CMR, with echo, where you can see ventricular interdependence by observing respiratory variation across the AV valves, we can similarly see the same process using real-time imaging and just observing the heart as the patient free breathes. And what you'll note, what you hope to demonstrate to you is the presence of ventricular independence. And what you'll see in these images is, as just as Karla had nicely explained, is that when this patient takes a deep breath and the diaphragm drops, flow increases onto the right side of the heart. But in situations of constrictive pericarditis, where now the heart is constrained in a cavity, one ventricle's filling has to occur at the expense of the other. And what you'll note is when the patient inspires, flow increases to the right side of the heart, and immediately the septum will push towards the left. So this is objective evidence of ventricular interdependence, which is objective evidence of dissociation of intrapericardial and intrathoracic pressures. We can also look at how the pericardium and the myocardium behave. Generally, in these processes, the pericardium and myocardium are dissociated from, generally the myocardium and pericardium are function independently of each other. With these tag sequences, we can actually see that the pericardium and myocardium here are adherent and moving in the same direction. Similar to what is done with echo, we can also try to look at respiratory phases, changes across the AV valves. We can do this with real-time phase contrast flow, and there's some papers on it where you, if you wanted to, you can document this as well. Now, those are the things that all the other tests had already told us. What is unique to CMR and where does it add value, right? So here is our SSFP images. I showed you the T1 images, which showed us the very markedly thickened pericardium. But we, again, have the ability for tissue characterization. So one sequence is, as we had talked about, is the sequence T2 imaging, where we're looking for edema. And I hope you'd appreciate, as I had shown you in the acute pericarditis cases, where you have intense hyperenhancement of the pericardium here in all of these images. So the pericardium here on the T1 images is right here as this dark structure, and this appears very bright on the T2 images. Water on T2, anything that has water on T2 images will appear bright. So this is a sign of edema. Whereas when you give gadolinium, you can see now there's diffuse hyperenhanced gadolinium all throughout the pericardium. So the question is, does this add value? Does this change how we change our management? So what does this LGE really mean? So this is a study of about 25 patients with known diagnosed constrictive pericarditis who actually went to the operating room for pericardiectomy. And all of these patients had CMR. And what they found was those patients who showed intense LGE uptake, this is the histological correlation for this was very active, dynamic, inflammatory reaction going on in the pericardium by histology. So there was a lot of neurovascularization, there was a lot of fibroblasts present. So LGE uptake by the pericardium is a marker of a very intense ongoing inflammatory reaction by histology. So a question I have for you now is, did CMR change your management? Would you have done anything different than if you didn't have this knowledge? And these are some of the, if you didn't have the CMR, maybe you would have sent this patient on to pericardiectomy, or maybe you would have considered a left or right heart cath. But I hope after this, I would have convinced you that with such significant active inflammation, to consider anti-inflammatory therapy. And in fact, this is what this patient got, and I hope you'll now be able to see how we can actually track serial changes in the inflammatory response of the pericardium. You can see now the pericardium actually, you can barely see it, whereas it was previously that very thick rind. The T2 imaging, remember, anything bright indicates water or edema. That brightness has completely resolved. And if you look at the LGE, there's no longer any white hyperenhancement around the heart. So this patient actually completely resolved their constrictive physiology. And just as a, drive home the point if I haven't already, here's the pre and post pictures. How about this case? This was a 62-year-old, atrial fibrillation, right upper quadrant discomfort, lower extremity edema of several years duration. And here's where his cardiac MRI pictures. I hope you'll notice a couple of things. The atria look engorged, the ventricles look tubular in shape. If this were to play long enough, I hope you can appreciate the diastolic shudder. If you look at the IVC, the systemic veins are all engorged. All of this right away would have led you to the correct, both the morphology and the physiology would have led you to the correct diagnosis of constrictive pericarditis. Would there be any value of CMR in this case? So, So here are the T1 images. As notice here, you see some very dense blackness right here anterior to the RV. You can see it here. And this is, this very dense darkness. This is the pericardium that's markedly thickened and maybe even a little bit more. We'll talk about that right here. And that's probably what's compressing this right ventricle, preventing it from expanding. Look at the T2. No evidence of edema in this particular image. Look at the LGE. No evidence of hyperenhancement. So based at least on what I've told you, this would not be a patient who you would think would benefit from anti-inflammatories. And you would be correct, because this patient also had a non-contrast CT. And remember, I told you CT is a fantastic test to look for pericardium, for calcium. And you can see we didn't see calcium very well. All we saw was this ragged darkness that was suspicious of pericardium, for calcification. But you can't actually 100% be sure it's calcium. Whereas here, I think there's no doubt in anybody's mind that this is very end-stage constrictive pericarditis, where the pericardium has completely calcified, and there is no role of anti-inflammatory therapies here. This patient needs to go to the operating room.
So how would you tell that from somebody with TB? Because TB pericarditis is also associated with all those calcifications.
Yeah.
How pericardial diseases change. We see less and less and less of this.
That's true.
More of inflammation.
Yeah, so if we were, you're right, in a third world country, this could very well have been a case of TB pericarditis. Yeah, absolutely. And this is just what this study shows. Another study showed that, in patients who had reversible constrictive pericarditis, they all had the presence of intense LGE, whereas those patients who did not reverse did not have LGE. And this is just an example of why also CT can be very helpful. This patient went on to the operating room, but it can be very helpful if you can create an image like this where you can really guide your surgeon. He has a very good idea in his mind of the extent of surgical excision of the pericardium that he will have to perform. So CT can be very helpful also in the preoperative phase. We're used to talking about it for analyzing the coronaries and the grafts, but in this particular case, actually giving the surgeon an idea of the extent and location of the amount of calcium that's present around the heart. How about this case? This is a non-ischemic cardiomyopathy patient with right heart failure symptoms. He has exactly everything all these other patients I showed you had. Recurrent pleural and pericardial effusions. He is also, physician thought about pericardial disease. He's been referred for pericardial evaluation. Here are his T1 images. Here you can see the pericardium is thick, again, anteriorly. I believe this was like in the intermediate range. It was about 3 millimeters. But look at this. Look when I turn on the LGE. This time there's no uptake of pericardium in LGE uptake in the pericardium. Rather, there's intense LGE uptake in the muscle. So this was a myocardial process, not a pericardial process. And this was actually a diagnosis of cardiac amyloid. Okay. So what about the other diseases that we see in the pericardium, pericardial masses? You heard it from Karla. You know, I think we're going to win hands down when it comes to masses. And it's a little important to know what your differential of a pericardial mass is. The benign stuff are usually cysts, and usually everything else is generally going to be metastatic. The most predominant mass to the pericardium is going to be some sort of metastatic process. The most common culprits are lung, breast, lymphoma, and melanomas. CMR and CT, awesome techniques to be able to identify the pericardium, identify the abnormalities of the pericardium, see the relationship to surrounding structures, to help you establish a diagnosis and assess for any complications to the heart from the mass or tumor that you're establishing. CMR's big advantage is, of course, tissue characterization, which I cannot harp enough on. And really, this is a great case I want to show y'all. Here's a 23-year-old female. She's admitted for nausea and vomiting. Her echo showed a mildly depressed EF, 40 to 44%, and a CT was ordered in the emergency room. Take a look at these images. I hope you'll appreciate, you see, bilateral pleural effusions. And those who have not seen this case before, do they see anything else that's abnormal? So just for the sake of time, I'll take the silence to mean nothing was seen. All right, here's the CMR. So what we're looking at is now you can see a very large mass sitting right on top of the right atrium. And why I bring this case, and here's the PET images, if in case, it's a multimodality conference, I'm going to bring in everyone. So, Dr. Al-Mullah did this case, and you can see that, the pericardium just lit up. I'm sorry, this mass lit up. So this was an RA sarcoma. So my point being is, CT, we have to be a little careful because CT attenuation of here in this particular case this was a non-gated study, number one. Yes, it was done in radiology, but the CT attenuation was very similar to what was maybe some effusion or, some other structure, and your eye had difficulty identifying an abnormality. Whereas because of the tissue, superior tissue characterization with CMR, it can become very easy to identify masses and other abnormal structures. Main take-home point for when it comes to masses, again, this is not a CMR lecture, but a general lecture. Main thing we like to stress is that anytime, if you take up contrast, if a mass takes up contrast, it's something bad. It's a tumor. Now, whether it's benign or malignant is a different question, but if you have contrast uptake, it is a tumor. And so this is just a case of a sarcoma, and you'll notice that in T2 imaging, edema imaging, it's bright. It indicates it's got water in there. It's edematous, And then on first pass perfusion, it takes up contrast. On LG, it takes up contrast. This turned out to be a sarcoma. What about something like this? This was identified as an abnormality on a chest X-ray. You can see here on the SSFP images that you have this very round structure in close proximity to the right side of the heart in the right AV groove, right claustrophenic angle, I'm sorry. And here we can use tissue characteristics to figure out exactly what this was. This was actually a benign pericardial cyst. But the main point, I want to harp on for this portion of our discussion is that this structure did not take up any contrast. So we knew it was a benign structure. It did not take up any contrast. It was not a tumor. And then we used T1 and T2 to figure out whether this was a cyst or not. All right, and so for the last thing, on the spectrum of disorders of pericardial disease, what about congenital processes? This was a patient of Dr. Zogby's. Here was his ultrasound. He got a call from his echo tech saying, you know, this is a very weird heart. The heart is not in the correct planes. Everything seems to be off axis in your patient. And so Dr. Zogby correctly had a very strong suspicion after having seen this previously, what it could be. He sent for a confirmatory test, a chest X-ray, and maybe even a CT scan here, and you can see some very characteristic findings. One, the chest is completely in the left side of the heart, and then you can see here that between the aorta, we call this the aortopulmonary window, there should be pericardium here, an exclusion of the lung. Rather, what you're seeing is lung interspersed between the aorta and the pulmonary arteries. And so this is very pathognomonic of congenital absence of pericardium with leftward displacement of the heart because there's nothing restraining the heart to the left side of the chest, and this very pathognomonic where you have lung interspersed between the aorta and pulmonary artery, and you can actually see that on the chest X-ray as well. So I hope you enjoyed. There has been other, that was a case of complete absence. Here's a case of partial. I've never seen this. I think Dr. Shah has said he's seen one case where you actually had herniation of the heart through the defect of the pericardium. So that's kind of interesting. So don't forget, by appropriate use criteria, advanced imaging techniques are recommended for suspected pericardial diseases. And in summary, I hope I've proved to you that these are powerful complementary tools and definitely additive in value. I hope you will consider these tests whenever there's diagnostic or clinical uncertainty. CT is a great test for looking at calcium, for looking at the morphology of the pericardium, and for preoperative planning. And CMR will do everything else. And if y'all have any questions, Dr. Shah just left. I'm just kidding.